Yo, y'all wanted more of Andre Picard? We are delivering. We're talking cannabis. We're talking pharmacare. We're talking medical assistance in dying. We're talking privatization of healthcare. Episode 14 with Andre Picard. Let's go.
Welcome to Solving Healthcare. I'm Kwadwo Karamante. I'm an ICU and palliative care physician here in Ottawa and the founder of Resource Optimization Network. We are on a mission to transform healthcare in Canada. I'm going to talk with physicians, nurses, administrators, patients and their families because inefficiencies, overwork, and overcrowding affects us all. I believe it's time for a better healthcare system that's more cost-effective, dignified, and just for everyone involved.
Thanks for tuning in, everybody. We are super excited about this episode with Andre Picard. We cover a lot. We cover some of the questions that we saw on social media, on Twitter, and on Facebook. But what I want you guys to really take away from this episode is how a lack of clear objectives and goals within our healthcare system really can impair care and impair resource utilization. I think that was a huge eye-opening point that Andre and I get to talk about here in this episode, amongst the other things, but it's a real eye-opener. Every other area within business, healthcare, your own health, your career goals, all of us have clear goals and objectives, but what are our goals in healthcare? Is it to reduce infant mortality? Is it to improve on mental health services? What are our objectives? These are the real questions we should be asking ourselves. Okay, before getting into the show, I want to tell you about our sponsors, BetterHelp.com. As I said, I love these guys. They are online counseling service that provides accessible, affordable, and convenient counseling services that is readily available via video chat, via telephone, via text messaging, and they cater to your needs, whether it's teen counseling, whether it's marriage counseling, whether it's healthcare providers addressing compassion fatigue. They're fantastic. So if you guys are looking to sign up, use promo code Solving Healthcare and you'll get a 10% discount on their services. Our other sponsor today is the podcast Critical Levels. This is hosted by my boy, Zach Cantor. And this show is awesome. It's about paramedicine and the issues around paramedicine, but they also dive into issues that involve us all. Specifically, he had a great episode with Dr. Zemek about childhood concussions, which as a father of 3 boys that are involved in hockey, I was completely engaged in, and it was a great conversation. This guy's going to be a star. So if you guys are game, listen to him on iTunes, Spotify, or Stitcher, anywhere you could listen to podcasts, and it's a guaranteed gamer, man. Good job, Zach. Lastly, I want to give a shout out to the Department of Medicine at the Ottawa Hospital. These guys have supported this show tremendously. I want to give a shout out to Abhilash, Sandra, and Dee Dee, Tracy. You guys are amazing. They've assisted with marketing, an updated website on the Department of Medicine page. I'll leave links to that on the show notes. It is proper. But yeah, love you guys for all the support and appreciate it. All right, let's dive into it. Andre Picard, the author of Matters of Life and Death, and you heard him on episode 13. Amazing journalist, 40 years of experience, and he really delivers on this episode. We talk about it all, and I can't wait for you guys to listen to it. So we're just going to dive into it. Enjoy episode 14. So I touched a bit on universal healthcare and how I'm not sure in Canada we could truly say that we have universal healthcare. I'm wondering if you had any thoughts in terms of privatization. You know, this is coming up a lot in terms of ways of making healthcare more sustainable, dealing with wait times and so forth. What are your thoughts in terms of privatization?
Well, let me start with the universality part of the puzzle. So we have in Canada, we have this notion that we have a universal system, but we have the least universal healthcare system in the world. I think once you put it in those terms, you go, oh, hold on, is that true?
The least.
And it is, because we cover hospitals and we cover physicians 100%. but we cover very little of everything else. We cover about 45% of drugs publicly, about 30% of home care, 35% of long-term care, 6% of dental care. We're all over the map, and it's irrational. So we don't have a universal healthcare system. So that's the first part of the puzzle. I like to use the analogy of a basket. So we have this Medicare basket of services. Right now we have a basket that's very narrow and very deep. It's hospitals and physicians. We pay for all of it, even though some of it probably shouldn't be paid for. And then the other stuff we don't cover near enough. So I think we need to make this basket a lot wider and a bit shallower. So we cover a lot more, but we give some people some responsibility for the rest. So that brings us to the second part of the privatization talk. And I think a lot of the talk about privatization in Canada, the way to shut down any discussion about healthcare is to say, oh, you're going to privatize, we're going to be like the US. So I think that's nonsense. I think it's a false dichotomy. I think the reality is no health system can cover 100% of everything for everyone all the time. So we're going to have some private healthcare. So we have to realize that from the outset. So the question is not, will we have private healthcare? The question is, where do we have it? How do we regulate it? And how do we make sure that everyone gets the essential care that they need at an affordable price? So we have to have these philosophical parameters. And then how we deliver the care, to me, it doesn't really matter. I don't care if it's delivered by privately, publicly, a mixture. What matters is that people get the care and that it's accessible and that it's affordable. So that's my philosophy. I get some grief for that, but I think that's how we have to have the discussion about privatization. It's not black and white. It's about how do we regulate it? How do we ensure that it's delivered fairly and comprehensively, etc. So I think in Canada, the problem we have is we have badly administered public health care and badly regulated private health care. So we kind of have the worst of both worlds. A lot of European countries have a lot of private health care, but it's very strictly regulated. It's not a free-for-all the way it is here. So there's different ways to get that balance right. And again, I'm ranting, but you got me on my pet topic.
No, that's part of my game. It's interesting because actually I've never heard that framed that way, is that we're how'd you put it in terms of universal healthcare? We're the
least universal healthcare.
Yeah, I like that. And I mean, because it's often people forget that they're like, oh, we don't have any private healthcare in Canada. But, if I go see a physiotherapist, I'm paying out of pocket. And it's true. It's like, where do we want to put our private resources? I mean, some of the topics that come up or worries I hear people mention is like resource drain, where like some of the best surgeons or physicians or whatever allied health professionals would just strictly go into the private sector. But it's kind of like you mentioned, if you're like anything that you're going to do that's semi new or complicated, it will take some nuance. And so, yeah, maybe you need to restrict how much time physicians could spend in the private sector. Maybe that's a solution. But certainly to think that we can't have any element of private healthcare in 2020 or beyond, I think is a bit ignorant at this point.
Well, and you're right. It's about setting parameters. So if you look at a country like France, many doctors practice in the public system and the private system, but there's strict regulation. So if you want to work in the private, for every hour you give to the private system, you have to give an hour to the public system. So that's a way of getting some balance there. Mm-hmm. So it's not, it's not an either or. In Canada, you can opt in many provinces, not all, but in many provinces, you can opt out of the public system and then you can charge whatever you want. There's no limit. Mm-hmm. And I'm not sure that's a good system. Now, very few doctors do, because our Medicare system is actually very generous for doctors and it's a good system. Very little bureaucracy compared to systems like the US. So the greatest beneficiaries of Medicare have been physicians. So we shouldn't forget that.
Yeah. I feel like it's so taboo, but we need to go there. And I don't know what will make us go there. What I'm getting at is, what is our breaking point? Because baby boomers are getting to prime time healthcare utilization age. We keep saying that we can't keep this up in terms of healthcare delivery and spending. So what's next? Like, what do you see? What's going to happen? in Canada, in your humble opinion?
Well, I think that we have to realize that healthcare is really important to us. We have to find a way of delivering it. And as I said before, we obsess a lot too much about the cost. Do we spend too much on healthcare? I'm often asked that question, and I always give the same glib response. I always say, I have no idea because I don't know what we're trying to achieve. So we just spend, we spend the way we spend. We don't have any set public health goals in Canada. So unless you have goals, it's hard to say if we're achieving what we're trying to do. So I think we have to do some basic stuff.
What kind of goals would you have would you have in mind?
Yeah, so I look to many countries do this. So you look to a country like Sweden. So Sweden publicly publishes every year a list of its public health goals. So for example, I take one in Canada. In Canada, we have an abysmally high rate of child mortality compared to most of the world. So I would say in Canada, we want to bring our rate of child mortality from 3 per 1,000 to 2 per 1,000. That would be a public health goal for me. And then we find out a way to do that. And we spend the money that's necessary to do it. So that's how you have goals, and then you work to achieve them. People often get uncomfortable when I say, we have to treat it more like a business. And that's what a business does. A business says, here's the goals for the year. Often those goals are related to profit, but that doesn't have to be the goal in healthcare. The goal can be, we're going to ensure that our child poverty rate falls by X percentage points, or that the cesarean delivery rate is going to be less disparate from one end of the country to the other. So there's all kinds of goals you can set. And once you have goals, it's easier, I think, to figure out how to spend appropriately.
You know where you're trying to go.
Yeah.
You have purpose. Yeah, it's funny because you always hear on a lot of whatever endeavors that you go on that, you need to set goals and write them down or discuss them, be clear on what your objectives are. And it's funny, if you ask me what are the goals of Canadian healthcare system, and that's not an easy question. Yeah, to make Canadians healthier or whatever, but is that really specific enough? Is that what does that actually mean? Yeah, no, that's a great point.
When I do talks, I often ask the audience, I say, what is the statement of purpose of Canadian Medicare? So we spend $250 billion every year, $256 billion on healthcare. What is its purpose? So I often ask that to audiences, and the answer is always silence. So I tell them, you're right. We don't have any. You're all right, to answer nothing. And when you put it in those terms, I think people go, wow, we spend all this money and what's the purpose of it?
Yeah. Wow. I'm actually speechless. Because, what really is our goals? Yeah. I mean, even if you think about it in specific niches, when I'm in ICU, I know my goals are clear. When I'm in the palliative care, my goals are clear. When we look at a system level, it's not clear at all. We might have a bunch of issues, but we're not prioritizing them. We're just blanketly throwing money and dealing with fires. Wow.
And palliative care is a really good example. You have very specific goals once the patient is there. But what are our goals as society to ensure that the right patients get there? In Canada, between 17 and 35% of people who should have palliative care get it. We do a terrible job of ensuring people are treated well at end of life. And, it's hard to imagine something that's more important than alleviating people's pain at the end of life, to not see them die a horrible death. And we don't have goals. We haven't made that a priority. Again, it's the Canadian classic thing. Once you're in palliative care, we have fabulous palliative care. But so many people are denied access to that it's criminal.
Yeah, and the thing that people may or may not realize is, even when it's studied, the benefits of early palliative care. There's a study out, it's almost 10 years old now, that there was stage 4 cancer patients that got either early palliative care or just standard care, up to the discretion of their team. And the patients that got early palliative care, not only were their symptoms improved, but they actually lived longer, ironically. And so, I mean, you're definitely preaching to the choir in terms of palliative care resources. I mean, when you look at trying to improve the experience for the family, for the patient, making sure that, they're not suffering. And, even from a resource point of view, like the patients are less likely to occupy acute care beds as a result. It's just, it is a bit mind-boggling that this is not emphasized more.
Yeah, and it's a reminder. What you're saying is a reminder. I don't think we lack money. I don't think there's any lack of money in our system. We're one of the biggest healthcare spenders in the world, but I think it's how the money is allocated is the problem. We don't spend smartly. We don't get value for money.
This is like my mission, Andre. It's like I see it day in, day out, us putting in money into interventions that have no benefit. Even there's a very simple example, but I think it clarifies things. You could have, if someone comes into the ICU when they need to be resuscitated with IV fluids, there's normal saline that we've all seen that costs maybe $1.30. And then there's some more sophisticated fluids that cost about $50 to $60 for the same amount of volume. So 60 times the price with no, like if you could study it through the yin yang, there is no additional benefit for you getting that fluid, and we spend thousands on it, and there's no reason for it. You could have an oral antibiotic that's just as effective as an IV antibiotic, but people will still order the IV one because it makes them feel better. Throwing away money just because, for lack of understanding or just because of a lack of a will to change. It's all over the place. And then instead we could be putting it into places that matter. This is what drives me nuts. I see my physiotherapist position gets cut. I see my social worker position get cut. Things that actually are going to make a difference into the patient experience and in improving care. I'm going to have to cut these positions. It's crazy to me.
Yeah, and you remind me I remember visiting a unit for girls with eating disorders at a hospital, and they had cut the psychological care. So they were no longer getting psychological care. So what was the result is they ended up spending many more months in hospital at tremendous cost, way more money than it costs to fund a psychologist. It's a different budget, etc. Just a lot of irrational stuff like that happens, and it actually costs more money, not less.
Exactly.
People 90-year-olds with dementia and cancer getting a hip transplant. What's the point of that?
Absolutely. It's and stuff that has been studied and we know are unlikely to benefit, and we still offer it. And, when you give that example of arguably who might be the most valuable person in a eating disorder ward, I would think it would be the psychologist. Wow. That reminds me, we did get a bunch of questions on Twitter when we were doing the show, and one of them.
I saw that there was quite a daunting list.
You're a popular man. One question that really stuck with me, and I don't think there's an easy answer to this, is how do we break the cycle of these 4-year cycles where governments are in power, and so the budgets are reflective of that. So there's so much short-sighted, budget interventions, cuts, because we got to balance the budgets, despite the fact that some of these cuts are going to make things worse in the long run. Is there a solution to this problem?
Well, again, I think there is a solution. And again, we can learn from looking at other jurisdictions. I think one of the things that distinguishes Canada systems is the level of political micromanagement. So there's way too much interference from the health minister's office reacts to what's on the front page of a newspaper. That's how our system runs. It's like, I always call our health ministers firefighters instead of fire prevention officers. And that's what they should be doing. They should be setting the philosophical goals, as I talked about before. These are the goals we want to achieve, and we should have professional administrators running the system. So that's what I see when I go to countries in Europe, like the Netherlands and France. They're professionally managed. They're run like a business, and the government essentially keeps their nose out of it, and the public doesn't want their nose in it. So I think it's really to let the managers manage. One of the worst jobs in Canada is to be a healthcare administrator, because you have all this responsibility and you have no power, and you're constantly second-guessed by politicians. It's a terrible position to be in. So what do? They just cover their butts. They try and not make waves, and we just go along, try and keep quiet, not Nobody wants to catch the attention of the Ministry of Health because it's always going to be bad news. So I think it's this professionalization that we have to aim for. And it's weird because we don't do it in any other part of our government. The transport minister doesn't call and tell the airport what flight should be going out. But that's how it works in healthcare. It's absurd. So I think that problem is easily solvable, but it's going to take some political guts for people to say, listen, hands off. I'm going to let Ontario Health. So, take Ontario Health, this new system. Theoretically, you should be able to do that. That should be an independent entity. Government gives them their allocation of money. Go for it. Run it the way that it should be run. That's how a system works in most countries, and that's how it should work here.
Have you seen a province healthcare system that works better than others?
Yeah, it's funny. When I travel around the country, I always know that's going to be the first question when I do a talk. We're obsessed in Canada. Are we the worst, or are we just sort of in the middle? That's everybody wants to be
the competitive nature of Canadians.
So I think the answer to it is we don't know because we don't measure things very well. I think anecdotally we know that every province does some stuff really well. So we all have areas of excellence. I often describe Canadian Medicare as islands of excellence in a sea of mediocrity. So we have a lot of mediocrity, but we have a lot of great stuff. So New Brunswick has tremendous paramedicine. Manitoba has really good home care. Quebec has really good primary care with CLSCs. BC has a really good handle on its drug program. So there's all these provinces that do things well. And the frustrating thing for me is we don't learn from each other and copy each other. We do quite the opposite. We always try to reinvent the wheel. But to get back to your initial question, who does it best overall? Now, I'll just go with my gut feeling because, again, there's no measures. But I think these days, I think it varies. I think Alberta used to have by far the best health system. It sort of pioneered the regionalization model, and it did it really well. It allowed the regions to run in the way we talked about, you're the boss and you run it, and the government kept its hands out. And until the government started meddling again, that worked really, really well. So I think Alberta was a leader for a long time. I think now probably Saskatchewan. Saskatchewan is a really good size, about 1 million, really good size to run a system. Ontario is, kind of a dog's breakfast. They're trying to fix this with a reorganization, but it's really the most disorganized system. As a result, I think one of the ones with the worst outcomes, unfortunately. I don't think there's a best and I don't think there's a worst, but there's a lot of good and there's a lot of bad overall, unfortunately.
No, I can appreciate your answer. I'm originally from Alberta, and one of the things that was taking place before I left was single electronic medical health record. They had this, I'm forgetting the name off the top of my head, but, taking the bull by the horns and saying, this is ridiculous. We should all be under one system, and all hospital charts should be able to speak to each other to a certain extent. And this was in 2005 when I left. So yeah, I could see where you're coming from. And yeah, at the time they still had the health authorities is what they would call them, which pretty much had, as you described, free reign, relatively speaking, to work in the way that was most effective for their community. It's a really good point you bring up, though. It's, a little bit more independence for some of these administrators to try and do the right thing for their community and to be able to get to their needs. Yeah, that's a fair point, and that you don't hear about every day. But yeah, certainly in Ontario, this is what we're attempting. I'm going to ask you a bit of a controversial one too. Is there a party that you feel like, since you've been doing this for 40 plus years, that seems to do a better job of this than others?
Well, I think one of the biggest problems in Canadian politics is that there's very little difference between the parties. We have violent agreement on, essentially the status quo. And that's, to me, it's always frustrating to me during election campaigns. There's very little discussion of healthcare because there's no disagreement. Everybody sort of has this, Medicare is great and we don't want to talk about it attitude. NDP, conservative, liberal, all the same approach. And I think a lot of it goes back to, there's a famous quote attributed to Joey Smallwood, who was the Premier of Newfoundland, one of the fathers of Confederation. he once said that I've never had a discussion about healthcare that didn't lose me votes. And I think to this day, politicians feel like that. You start talking about healthcare and it becomes a losing proposition because you can never satisfy everyone. So the parties kind of agree to say nothing. So we have these little discussions around the edges occasionally, but there's never any serious talk of reforming healthcare, regardless of the party. So short answer, no, there's not one that's better than the other. What we do know is that the lesser a party's chances of being elected, the more bold their promises are for healthcare. So that's the sad reality.
Fair enough. Okay, I'm going to touch on a few more questions that some of our fans were asking. So in terms of new cannabis legislations, what's your overall opinion on our approach?
Yeah, so I've been long a proponent. If I don't believe that, drugs should be regulated the way they are now. I'm a big believer in legalization of all drugs because I believe people are going to use them and we have to make it safe for them to use and educate them, etc. So that's my premise that I operate from. Lots of people don't like that view, but I have a very libertarian view about drugs, and I think it's built from a public health perspective that's the most rational approach. Now, when we take cannabis, I think the legalization of cannabis was long overdue. We started discussing this in the 1970s with the Ledane report, and finally, 2 years ago, we got around to legalization. Now, what's happened since then? I think it's been kind of a bust. It's been a bust economically, socially, medically, because we've replaced this criminalization with a whole bunch of stupid regulations. There's way more laws about cannabis use now than there were before it was legalized. So it's kind of we've undermined what we were trying to do. From the business perspective, that's the story that gets the most attention in Canada is our cannabis companies are all going bust because the sales are not what they expected. We could have built an industry here that exported its knowledge around the world, but there's so much red tape and regulation that we've denied ourselves that right. So I think we've kind of messed up this good idea. We've done it very, very badly, unfortunately. So the reality is what? The reality is a lot of people still buy on the black market. The government stores have product, but they have long wait lines. This is the Canadian way. We wait for everything. We even wait in line outside to buy our pot. So I think it's kind of been a huge disappointment, unfortunately.
Yeah, it's I do hear you about from a public health perspective on legalization, because certainly, putting somebody in jail or putting them in a spot where they can't have a job based on a substance that people are going to use anyway seems, not right. But my concern personally is the use, especially amongst the youth. Like, I think there's some detrimental effects that maybe we're not appreciating. Like, I know we see a little bit more psychosis in late adolescence, early adult age. I just kind of wish it was studied a bit more before we're like, hey, let's just throw it out to the world. But I do hear you from the public health side for sure.
The youth issue, whether it's cannabis, whether it's vaping, whether it's tobacco, that's a particularly challenging one. And those things are all illegal. It's always been illegal for young people, probably always will be. And that's not the issue. That's not the way we're going to deal with that demographic. We have to teach them. We have to recognize that they're young people, so they're going to be risk-taking, they're going to be experimenting. And we have to deal with that reality instead of being moralistic about it and saying, we've got to ban vaping, we've got to ban cannabis. They're going to use it. So let's make sure that when they do it safely. They do it rationally as much as possible for a teenager to do anything rationally. I think we just have to be much more pragmatic about this stuff.
Yeah.
And I think that's the big lesson I've learned about writing about public health for a long time is you really have to put your opinions aside and be very pragmatic about this stuff and realize it's going to happen. So how do we make it as safe as possible? How do we reduce harm? Harm reduction has to be the driving force of our public policies. Mm-hmm. And the worst thing for harm reduction is prohibition. Prohibition has always failed, regardless of the substance.
Mm-hmm. Yeah, fair enough. I guess it's always a question, which I guess we don't know, is just, what is that safe level? What is the amount or the approach that, is truly reducing harm. But yeah, a lot of questions in terms of, the approach. How about another question that came up was regarding pharmacare? I think you've written a bit about pharmacare in Canada. Any thoughts on that?
Yeah, so an issue we've written a lot about because it actually did get debated politically. Again, I think pharmacare is necessary. We need to, we're the only developed country aside from the US that doesn't include drug coverage in our universal health plan. So that's something that's needed to be fixed for 50 years. So we have to do that. So we've done it to a certain extent, but we've done it in a very haphazard way. So we have 102 public drug programs in Canada. So we have to make some sense of that. We need some more centralization, some more logic. But I think the really important thing that's lost in the pharmacare debate is we have to define what we mean by pharmacare. So we have a lot of people talking about, we need this single universal system. Sure, that's one way of doing it. To me, it's not necessarily that way. But the most important thing is, what are we going to cover for who and why? So how are we going to get value for money for our drugs? And I think the way to do it is not to copy what we've done with physicians and hospitals. We've covered those 100%, and it doesn't work. We have a lot of waste. We have a lot of stuff that's not done because we spend too much in those areas. So I think we have to be careful not to repeat the mistakes we've made earlier. So I think we have to be a little smarter to decide what we're going to cover. And that to me is the essence of the debate. There's no question that we should cover drugs. They're really important if we're going to have universal healthcare. But universality doesn't mean covering every product for every person all the time.
Right.
Ensuring that everyone has the essentials in an affordable way. And those are different things.
Mm-hmm. Yeah, it certainly was one of the few healthcare-related topics that came up during this past election. And that was, it's funny, that was my exact thoughts when it came up. I'm like, what does pharmacare actually mean? Like, what are we actually debating here?
Yeah, there was no real debate. There was a bunch of platitudes that were uttered, but that wasn't debate because the parties never defined what they meant. They said we're going to bring in this program, but what exactly is the program going to be? And then the fact that the federal parties were debating this, neglecting the fact that ultimately it's up to the provinces, that was a big problem as well.
Mm-hmm. Excellent. So, okay, Andre, what are your thoughts on medical assistance in dying?
Yeah, so another issue that we took a long time to deal with. So I started covering that issue in the early 80s. Then it got a lot of steam in the early 90s with Sue Rodriguez, kind of died off for a while, and then came back. So that, again, we finally brought in this legislation to give people more choice at the end of life, to minimize their suffering. So I think that was a really big, important piece of legislation. Now, the problem was that the legislation was flawed and it was inadequate, and we've got to fix it. So we're at that point now. In fact, new public consultations have just started about expanding the MAID legislation. So that's going to happen. The court has ordered it. But it's always frustrating with these issues, how slowly we go, how cautious the politicians are. Thank God we have an activist court in Canada, or we'd have much worse healthcare. The courts have forced us to do stuff that we know we should do, but politicians are too wimpy to do on their own. Mm-hmm. So a really important issue. I think we have to recognize that very few people are ever going to get an assisted death. It's going to be 1-2%, a very tiny percentage. But I think it's a really important philosophical point, a theoretical point that people have choice at end of life. I think that's what's most important about this debate, is giving patients more control. And I think that we're going to see that now. We're going to see the really tough ones. Does that apply to people with dementia? Does it apply to people with mental illness? Does it apply to children? There's some really, really tough debates coming. But again, I stay in my bubble about being pragmatic. I think we have to give people options, and then we have to ensure at the same time that there are protections so that these things aren't abused.
Yeah, so basically what I'm hearing is we can't use the slippery slope argument as a reason not to implement this. People deserve to have that choice in terms of how they want to end their life.
I don't know how many times I've said in my columns that not every slope is slippery, but I think we have to remember that's kind of a banal argument. not every slope is slippery. We have to have buffers in place to ensure there aren't abuses, but that doesn't mean denying people rights who want them. And no one should be forced to have an assisted death when they don't want to. No one should be choosing assisted death for lack of alternatives, like lack of palliative care, lack of long-term care. That's unacceptable. But no one should be denied an assisted death who wants it, who's making a rational choice.
Agreed.
And we can do all those three things at once. They're not mutually exclusive.
Exactly. In your book, Matters of Life and Death, you touch on transgender issues. Where do you see some of these issues in 2020?
I think it's just an example of what we talked about at the outset. It's an evolution, it's a new patient group, a new demographic that's standing up and being heard, and the health system has to adjust. This notion of treating gay men was unthinkable in the 70s and 80s. They're a bunch of perverts. And we hear a lot of that same, when you're around a long time, you start to hear these echoes. And we hear that now about transgender. Oh, we can't possibly do that. We can't use different pronouns. The language has always been the same, but things evolve. Language evolves. Medicine has to evolve. And I think these developments are good. They challenge us. They force us to think differently. Unfortunately, there are abuses, there are wrongs that happen along the way that force us to deal with this. But I think it's a very positive development that we're talking about gender fluidity, that gender is a social construct. I think these are really important things for physicians and future physicians to think about and to talk about, and how do they treat their patients regardless of their gender or how they identify.
Super important topic, and definitely one for a future episode. Andre, what about the wait times we're seeing overall, whether in a merge or if you're waiting for a hip? Do you see any solutions in the near future?
Yeah, so again, I think wait times is a systemic issue. So it's about creating more flow in the system. It's about breaking the bottlenecks. As we talked about earlier, the long waits in our emergency rooms have very little to do with emergency care, right? They're all about bottlenecks. It's about inability to admit people, inability to get people out of hospital. We have this perversity in Canada called the ALC patients, alternate level of care patients who live in hospitals. I've done stories about this. I met a patient who's been living in a hospital for 10 years because there's no alternative for them. This makes no sense. It makes no sense from a business perspective. It makes no sense from a patient care perspective. Ethically, all these things are wrong and we have to fix them. But, in some provinces, 1/3 of all hospital beds are ALC patients. They're people who have been discharged but have nowhere to go. So this is how you deal with wait times, is you deal with things across the spectrum. No easy solution. It can't be overnight, but we have to correct the errors we've made of bad planning. We hear often and over again, oh, well, it's the aging boomers, that's what's overwhelming our system. We've known about the boomers for 60 years. No surprise here. It's just a bad planning, lack of foresight, and we have to fix it.
Agreed. But what can we do now? Like if I'm, the Minister of Health, or I'm the lead for a health authority, and I got these tons of ALC patients, what can we do?
Well, I think, again, if you look at it, say, from a business perspective, what do you do in a business if you have this problem? You have a mixture of carrots and sticks. So you start punishing hospitals that have ALC patients. Why did patients, the perversity is that hospitals actually like having ALC patients because they require less nursing care. They're understaffed on nursing. They get paid the same amount of money, require less care. So it's actually a good thing for them, which is wrong. It shouldn't be a good thing. So you have to punish them financially. And that will solve the problem pretty quickly. They'll get them elsewhere. We have to incentivize people to have more long-term care homes. Most of our long-term care homes are private businesses. We have to ask ourselves why people don't go into this business. That's because the rates suck. It's because there's way too much regulation. So we have to make it easier for people to provide spaces for people who need it. And then we have to deal with the other piece of the puzzle, which is home care. I think we have put far too many resources into people getting home care just to get them out of hospital quicker from short-term surgery. And we haven't invested enough in the chronic part of the puzzle. So again, from a business point of view, way cheaper to care for those ALC patients in their homes, costs a fraction of the cost. So take that money and use it differently. And if you don't do that, then you're going to be punished for it. So the carrot and stick approach, all this stuff is solvable. And I know it's solvable because I don't see these problems in other countries around the world.
Interesting. We kind of talked a bit about how to create change in healthcare, and you do bring up the carrot and the stick. And I mean, money talks. One of my main incentives to do research around cost is because that's a change language. That's the language of administrators, of politicians. So if you could show a financial benefit for any intervention, like that's when things actually start to move. And so withholding funds so that change can occur, I think it can go a long way. But certainly just sticking with the status quo is not good enough.
But I would add the proviso that if you're going to have carrots and you're going to have sticks, people have to have accountability and they also have to have power. So you can't punish a hospital for having ALC patients, but not giving them the power to resolve it. So I think, again, when you have regionalization is supposed to be the solution to this, right? So the way a regionalization is supposed to work is that they should say, here's our overall budget. We're not spending it well by having these people living in hospitals. We should spend it on home care, or we should spend it on long-term care facilities. So you have to have the power to move that money around. And that's how the issue will get resolved ultimately, if we give people accountability and power to fix things.
I love it. Trusting in the people that you've, invested into trying to make the healthcare system better.
We pay healthcare administrators a lot of money. Let them administer.
No, that's a great point, Andre. One thing I like to do is always end on a positive note and allow our guests to talk about a story or a time where they felt their job has had a big impact on in general. And you did give this story earlier about, the AIDS patient in Toronto, but is there any other time where you felt that you covering healthcare and being as engaged as you have been, that you've really made a difference?
I think there's all those little stories like we talked about, the one patient who got better care because of your story, little policy changes. Those are always moving. But to me, there are two big things in my career that stand out. I wrote for a long time about the tainted blood tragedy. So this came out of my coverage of AIDS. I started covering, there were 4 groups who were infected with AIDS, and one of them was always forgotten, this little group of hemophiliacs and transfusion patients. So we started focusing on them, and this became a huge story. It became an expose of one of the worst, probably the worst public health scandal in Canadian history. About 30,000 people were infected with HIV and hepatitis because of mismanagement of the blood system, because of lying to people, because et cetera. I have a whole book-length version of this rant, but that issue, the tainted blood issue, I think is one of my proudest moments because it really did bring relief to a lot of people. There was more than $5 billion in compensation paid out ultimately. That our drug regulation system changed profoundly as a result of that. And I'm not taking credit for that solely, but we did get the ball rolling. So I think that's a really important story in my legacy, if I could put it that way. And then another one, very similar, but on a smaller scale, but a very touching one, was work that I did with my colleague Ingrid Peretz on the thalidomide survivors. So as a group of people who were affected by thalidomide in the 1950s, 60s, left with missing limbs, etc. And a lot of those folks lived a long time suffering in poverty. And we came back to that a few years ago and wrote about these forgotten survivors. And again, the result was quite a large compensation package, people getting their lives back, people who were forgotten, we got to tell their story. And there's a lot of touching stories as a journalist to hear from that, and when you actually change people's lives. So those are two of the biggies for me, but all the little ones day to day, they keep you going.
Yeah. No, I got to tell you, Andre, it truly is a privilege to be able to have this conversation with you. And I could truly echo the amazing, inspiring work that you've done over the years. that it's impacted Canadians and people worldwide, and given, people a voice, increasing awareness on many healthcare related issues. And I got to tell you, I learned a ton today. I got no political, no policy game. I'm not educated from that front, but the things we talked about today were super eye-opening, especially like the silo stuff and the regionalization aspect of things, like the way you framed it. And it's just, I don't know, there's a lot to digest and a lot to think about, but I'm hoping my listeners are feeling similar to me and feeling pretty inspired. And I'm truly grateful that you took some time to do this. And I hope to have you on again.
Well, it's a pleasure. And, I always remind people, my job is to sort of summarize and to translate all this. I meet all these brilliant people, and my job is to sort of steal their ideas and make them pithy and accessible to the public. So I can't forget that I know nothing. I learn all this stuff from other people. And I think my only skill is really being able to boil stuff down and simplify it and hopefully communicate it in a way that people can understand and act on.
Yeah, well, I'll tell you, it's working. Awesome, Andre. Thank you so much. There's going to be links to all your books, your Twitter handle, everything in the show notes. And thanks again for doing this.
Great. Well, thank you. I look forward to it.
Thank you. Thank you so much for listening to episode 14 with Andre Picard. I hope you all enjoyed it. If you guys want to follow him on Twitter, it's Picard on Health. If you want to follow or support the show on Facebook, on Twitter, on Instagram at Quadcast, you can send comments to quadcast99@gmail.com. And please let us know how we're doing. We're looking to always improve on the show. Leave 5-star rating on iTunes if you're up for it.